Hello and welcome to the Above and Beyond Cancer Cancer Education Series, which is brought to you by the Holmes Murphy Foundation. I'm Chris Gooddale, the Executive Director of Above and Beyond Cancer, and it is my pleasure on a weekly basis to introduce our founder, Dr. Dick Deming, who will introduce our speaker. Dr. Deming?
Hey, Chris. Thank you. It's really an honor tonight for me to introduce to you one of my colleagues here at MercyOne Cancer Center in Des Moines. Dr. May T will be giving the talk tonight. Dr. T grew up in British Columbia. She went to a high school in British Columbia with, well, almost with, Ryan Reynolds went to her same high school. He was just a few years older than she is. And then she stayed in British Columbia at the University of British Columbia, where she did her undergraduate work and medical school, along with her surgical residency. And she did her fellowship in surgical oncology at the Mayo Clinic in Rochester. And we were so pleased to attract Dr. T to come to MercyOne Des Moines Cancer Center in 2018, where she has just been a wonderful addition with her talent, not only as a surgeon, but just her kind, compassionate way with patients. So it's been really a pleasure for me to be able to collaborate with Dr. T. We asked her to talk this evening about one of her specialties, and that is doing surgery on the liver, both for primary liver cancers, but also for liver metastases. And without further ado, I'll turn it over to my friend, Dr. May T. May?
Dr. Deming, thank you so much for those kind introduction and words. It's a real honor and pleasure to be here. I am going to start sharing my screen here. Chris, can you confirm that you can see this okay?
Looks great, yeah.
Fantastic. Again, it's a pleasure to be here. My name is May T, as Dr. Deming mentioned. I sort of wear three hats at MercyOne Des Moines. I practice surgical oncology with a focus on liver, pancreas, biliary tree surgery, as well as upper gastrointestinal surgery. I'm also actively involved in the general surgery residency program, and also in teaching medical students affiliated with the Des Moines University College of Osteopathic Medicine. So it's my pleasure to be here, and I'll be speaking about liver resections for primary and metastatic disease. I have no disclosure other than the fact that I love operating in the liver, pancreas, and bile duct, as well as upper GI tract. What I'm hoping to focus on are the following three things here. Primary liver cancers, secondary or metastatic liver tumors and their surgical options, and an evolving topic called liver resections for non-colorectal and non-neuroendocrine liver metastases. So what's the difference between a primary versus a secondary liver tumor? Well, primary liver tumors arise from the liver itself, and the liver has two main cells. It has hepatocytes, which are the liver cells, and they produce bile and they detoxify everything that we eat and drink that comes through from our gut. It has cells that line the bile ducts, and they're glandular epithelial cells, and those can form cancers as well. So you can get hepatocellular carcinoma arising from liver cells or hepatocytes, and you can get cholangiocarcinoma arising from anywhere in the biliary tree. And if you look at the biliary tree, there's bile ducts within the liver, there's bile ducts outside of the liver, and there's bile ducts actually that go into the pancreas and empty into the small intestine, where the bile juices and the pancreatic juices mix to help us digest our food. So those are primary liver tumors. Now, secondary liver tumors are actually more common, and they're more common because primary liver tumors are actually quite rare. And the reason why they're more common is because a lot of cancers of the gut will spread to the liver because all of the blood flow in the gut will go through the portal vein into the liver, where it'll detoxify everything we eat and drink, clean up that blood, and dump it right back into the heart for us to have clean blood circulating through our bodies. So those are secondary liver tumors. Most of them are GI tumors, like colorectal tumors or neuroendocrine tumors of the GI tract. Some of them are non-colorectal, non-neuroendocrine tumors, and they can also spread because the liver has blood supply like the rest of the organs in our body, and they can spread that way to the liver as well. So I'll first talk about hepatocellular carcinoma. As previously mentioned, it arises from liver cells or hepatocytes. It's the most common primary liver cancer of the two, hepatocellular carcinoma versus cholangiocarcinoma. Its incidence is actually increasing in the United States, and that may be to several factors, one of which is the increase in liver disease in general within the United States. Now, what I'm going to be talking about in several of my slides is this common theme of chronic inflammation increasing cancer risk in general. So anything that increases chronic inflammation of the liver will increase your risk of developing HCC. The reason for that is because chronic inflammation leads to cellular destruction, which leads to increased cell turnover as the cells are trying to repair themselves, greater chance of mistakes in cell turnover, accumulation of DNA mutations, and the risk of tumor genes being turned on or off that predispose you to developing these cancers. So the biggest risk factor for HCC is actually cirrhosis or chronic liver disease. And cirrhosis can be from hepatitis C, it can be from alcoholic liver disease, it can be from fatty liver disease. Basically anything that causes chronic damage and inflammation will predispose you to HCC. You can diagnose it several ways. A really good quality CT or MRI can diagnose HCC just on its own. The tumor marker associated with HCC, just like a lot of other cancers have associated tumor markers, is something called AFP, or alpha fetoprotein. And that can also be diagnostic. If neither of those two give the answer of whether this liver mass is HCC or not, usually we can take a sample of the HCC and get a biopsy that way with tissue. Now, there's many treatment options for HCC, and I'm going to go over that. But it basically depends on your stage, your liver function, and how you are in general with respect to your health. And really the only treatments that can cure HCC are either a liver transplant, a liver resection, removing the tumor, or ablating the tumor, destroying the tumor with either heat or cold, more commonly heat rather than cold. So this is a busy slide. It's based on the Barcelona Clinic liver cancer approach to management of hepatocellular carcinoma, and they arguably have the largest volume and experience worldwide of managing HCC. It's been widely adopted, and it's an algorithm that combines your stage of tumor, your liver function, and your performance status to basically give you management options for your HCC. Now, as you can see down below here, you've got management options of ablation, which is destroying the tumor cell, resection, transplantation, and these are the curative treatment modalities for HCC. And you have other things called liver-directed therapies like chemoembolization and systemic therapy. So I'm going to go over all of those modalities there with you guys here. The first one being a liver transplant. So you can think of a liver transplant as being something surgically similar to replacing a washing machine. You've got tubes that go into the liver, tubes that go out of the liver, and you just got to make sure all those tubes are connected correctly and none of them leak. And that's, in a nutshell, what a liver transplant is. So you take the bad liver that has the hepatocellular carcinoma, and you put it in, and you replace it with a good liver that doesn't have cancer and that doesn't have cirrhosis or chronic liver disease. Now, the reason why we don't transplant everyone with hepatocellular carcinoma, and the reason why there's criteria that need to be met for transplantation is because the number of people needing a liver transplant far exceeds the number of donors and livers available for it. And I just showed two different pictures, a classic transplant and a piggyback transplant, where the liver is piggybacked onto the inferior vena cava rather than having that all removed. So surgical therapies, this is where, this is what I'm passionate about because I don't do liver transplant here. But resection is basically removal of the tumor with the normal portion of the liver. And you can see here the hepatocellular carcinoma here, and us taking basically a wedge of this liver along with the tumor and completely resecting it. Now, if resection is not possible, or if it's a very small tumor, usually less than 3 centimeters or just over an inch in size, we can do something called ablation. And ablation can use either heat, most commonly, or cold, something called cryoablation, to destroy tumor cells. The heat we use at Mercy is something called microwave ablation. And you can use either that or you can use radio frequency waves. And the reason we use microwave ablation is because it more reliably destroys tumor cells, and it doesn't have the same heat sink effect that radio frequency does, where if it's close to a blood vessel, the tumor, the blood in the blood vessel actually cools down the tumor and reduces the effect of that heat destruction on the tumor. Now, most studies will say for hepatocellular carcinoma that the survival for resection versus ablation is actually equivalent if you have a small tumor, and that's a tumor less than 3 centimeters in size. There may be slightly higher recurrence rate with ablation, but the reason why we use ablation for small tumors is because it's much safer. There's less blood loss, it's a quicker recovery, and there's less surgical risks, risk of bleeding, risk of bile leak, risk of liver failure. All of that is decreased with ablation versus resection. So it's actually a very good option. And we do a lot of both here at Mercy, depending on the patient and the tumor characteristics. Now, what if surgery is not an option? What if surgery such as resection, ablation, or transplant are not an option for a patient? Well, we have a lot of other things we can offer. So we can do something called transarterial chemoembolization, or TACE, and we can also do something called yttrium-90 or Y90 radioembolization. And I'll go over what those two mean. So TACE is where a radiologist actually accesses your artery through a puncture in your groin, very similar to if you were to get a coronary angiogram for your heart, and delivers a wire into the artery that feeds your liver blood vessels. And what the radiologist does is it delivers chemotherapy specifically to the blood vessels supplying the tumor. And as you can see here, this catheter is delivering chemotherapy to the right side of the liver. And these are the branches of the right hepatic artery. And after delivering that chemotherapy, the radiologist will then knock off the blood supply to the tumor. And what that does is it does two things. One, shrinks and controls the tumor. And two, it keeps the chemotherapy in that region so that there isn't as much systemic side effect or toxicity associated with that chemotherapy as you would if you would get chemotherapy through an IV that would go through your entire body. Now, Y90 is the same principle, but instead of using chemotherapy, it uses these radioactive beads that then seed the tumor and destroy the tumor, not with chemicals, but with radioactivity. So those are two things that we can offer patients who may not be surgical candidates or who may not have surgically resectable disease. And those two things are important to differentiate, because even if you don't have a tumor that's resectable at the moment, it doesn't mean it can't be resectable in the future if one of these modalities can shrink the tumor to the point where we can get it out safely for you. And that's what you want to do. You want to be able to get that tumor out or ablate it or destroy it reliably in order to cure the disease. So those are what we call liver-directed therapies for hepatocellular carcinoma. Now, what if that's not an option? Well, there have been a lot of really big papers and studies that have come out this year in 2020. And 2020 has not been a great year for a number of reasons, but it's been a great year for HCC research. One of these papers was published in the New England Journal of Medicine, which is arguably the highest impact medical journal we have here. And it was a randomized controlled trial, and that's our gold standard for establishing cause and effect with respect to treatments. And it was looking at these two drugs, this two-drug combination called Atezolizumab and Bevacizumab. I'll call them AB. Now, Bevacizumab is also known as Avastin. And it compared these two drugs with something called Sorafenib, which previously was the gold standard for chemotherapy for advanced stage hepatocellular carcinoma. Now, this was a multi-center trial. You can see all the different authors that were involved in this trial. It was recently published, and it involved over 500 patients. They looked at three main things. One was the overall survival between the AB group and the Sorafenib group. They looked at progression-free survival, and they looked at the toxic side effects between the two groups. And what they found was pretty promising. So as you can see, the blue line represents the AB group. So that's the new chemotherapy. The red line represents the Sorafenib group, and that is the old chemotherapy for HCC. And on the left side is the overall survival. And you can see patients in the AB group did way better than patients in the Sorafenib group. In fact, median survival wasn't even achieved yet in the AB group. And the survival at 12 months was 67% in the AB group versus 54% in the Sorafenib group. Now on the right-hand panel, that's survival without disease progression. So that's where you're surviving without your disease growing or anything like that. And the median for the AB group was over 6 months. It was at 6.8 months versus 4.3 months for the Sorafenib group. And so that was promising in terms of this new drug combination being more reliable in terms of improving overall survival in patients with advanced HCC where we can't do surgery or liver-directed therapies. Now, a lot of people will ask, well, if it's stronger, does that mean it's more toxic and it'll make me more sick? Well, the researchers thankfully looked at that question as well. And what they found was that the quality of life deterioration, kind of a double negative, but that was less with the AB group than Sorafenib. And the number of side effects was really no different between the AB group versus Sorafenib. So what this study concluded was that the AB group had improved survival, maintained quality of life, and did not do that at the expense of increased side effects than the previous gold standard, which is Sorafenib. So this has really changed our practice in managing patients with advanced unresectable HCC. It's no longer, it's a lot more of a hopeful situation than it was before. So now comes the question, well, if is there any way to prevent HCC if you have risk factors? So this was also a study that was published this year in the New England Journal of Medicine. It was not a randomized controlled trial, but it was a large study from a Swedish registry. It looked at a 10-year period between 2005 to 2015 with over 50,000 patients. And it looked at patients who had hepatitis B and hepatitis C, and they were chronic carriers. Even though we have an effective vaccine for hepatitis B, and we have some effective therapies for hepatitis C, there are still some patients out there that haven't responded to those therapies, and they are at risk for HCC, and they actually get screened for HCC. So what they wanted to look at was, is there any way to prevent HCC and liver-related mortality in this subgroup of patients? So they looked at whether low-dose aspirin could prevent HCC and liver-related mortality in these high-risk patient populations. So, like I said, it wasn't a randomized controlled trial, which is the gold standard, but they did this fancy statistical analysis called propensity score matched analysis that simulates a randomized control trial, because what they do is they create a model that predicts what treatment you're going to get. They match patients so that, you know, the patient in one group is pretty similar to the patient in another group, and they try to simulate a randomized control trial. And they looked at whether the group taking low-dose aspirin had decreased or increased risk of developing HCC, as well as liver-related mortality compared to the group who didn't take low-dose aspirin. So these were their findings. They found on the left-hand panel that the no aspirin user in the red line and the aspirin user in the blue line had differences in terms of their risk of developing hepatocellular carcinoma. Patients with chronic Hep B or Hep C who were on a low-dose aspirin for more than 90 days had a lower risk of developing HCC than those patients who weren't on a low-dose aspirin. And when they looked at liver-related deaths, aspirin, a low-dose baby aspirin daily, was actually protective against liver-related death as well. So I think that opens the door to maybe some primary prevention of HCC in high-risk populations. And that's not currently recommended in any guidelines, but I think it's kind of interesting. They've shown that aspirin, a low-dose aspirin, has been helpful in other cancers, particularly colorectal polyps, which can turn into colon cancer. So I thought this was kind of an interesting study, and one that was very recently published in a very good journal as well to share. So that's all I'm going to talk about for HCC. I'm going to switch gears and talk about bile duct cancers now. So bile duct cancers, or cholangiocarcinomas, are cancers that arise from the bile ducts. Now, if you look at this, this picture here, you can think of the bile ducts as a tree. And that's often why the biliary tree is called such. It's called a tree. It has the main trunk, which is the bile duct. It has a right branch, the right hepatic duct, and a left branch, the left hepatic duct. And it has a large fruit coming off the main trunk of the tree, which is the gallbladder. And the gallbladder inserts into the main trunk through a branch called the cystic duct. And that's actually an important dividing line for how we characterize cholangiocarcinomas. You just draw an imaginary line through the cystic duct. Everything below it is a distal extrahepatic. Everything between that and where the liver starts is called a Hilar or Klatskin tumor. And everything above this bile duct bifurcation, or where the liver starts, is called an intrahepatic cholangiocarcinoma. Now, there's three main types of cholangiocarcinomas. There's one that you form a mass, and it's like the circumferential mass around the bile duct, and those are easy to see on CAT scans. There's an infiltrating one where it basically grows along the bile duct rather than around the bile duct, and those form strictures on, or narrowings on imaging studies. And then there's an intraductal growth type where it looks like this polyp within your actual bile duct. By far the most common is that infiltrating, stricturing, narrow type of bile duct. And that's why they're so difficult to treat, because they grow along the trunk of the tree such that it's hard to completely remove all of it. And so we often have to rely on other things beyond surgery, usually chemotherapy and sometimes chemoradiation therapy, to augment the treatment of these types of cancers. So like hepatocellular carcinoma, the biggest risk factor for developing cholangiocarcinoma is chronic biliary inflammation. So that's anyone with primary sclerosing cholangitis, often associated with inflammatory bowel disease like ulcerative colitis, which in and of itself is a risk factor for, say, colon cancer. Choledochal cysts, which is a congenital anomaly of your bile ducts. They just didn't develop right when you were when you're in utero, and those can predispose to bile duct cancers, which is why we recommend removing those cysts before they do. Any kind of chronic infection, usually parasitic infections of the bile ducts that we don't see here in North America, but you can see in the developing world. And bile duct stones, either stones within the liver or gallstones within the gallbladder that then migrate to the bile duct. Similarly, diagnosed on CT or MRI, usually you need some kind of bile duct imaging, and that's an MRCP or ERCP. MRCP stands for Magnetic Resonance Cholangiopancreatogram, and that's basically an MRI specifically of the bile ducts and pancreatic ducts. And ERCP is an endoscopic version of a map of your bile ducts and pancreatic ducts. Now, the tumor marker associated with cholangiocarcinoma is something called CA19-9 or carbohydrate 19-9 antigen. It's not a reliable tumor marker because up to 20% of the population doesn't have the genes that express that tumor marker. But if you do, and if it's elevated, it's very supportive of the diagnosis of cholangiocarcinoma, and it's a tumor marker that you can follow after you've had treatment to see whether it's come back or not. Ultimately, you want to biopsy these if possible, and that's usually through the ERCP route where you go in through the stomach into the small intestine and go backwards up the bile duct in order to find the tumor to biopsy. Now, the only curative treatment for any cholangiocarcinoma is surgical resection. In certain types of cholangiocarcinoma, you can do transplant, and often both surgical resection and transplant need to be combined with chemotherapy and even chemoradiation therapy as well. So this is a patient of mine who presented to the ER one day with right upper quadrant pain. She was previously completely healthy. Because of her age and her gender, the ER doctors thought, oh, this must be her gallbladder. They did an ultrasound. Her gallbladder looked fine, but there was this huge liver mass on the left side of her liver. I subsequently saw the patient, ordered a CT, MRI, tumor markers, and did a biopsy and a PET scan and found that this was a primary intrahepatic cholangiocarcinoma, and it was completely resectable. So I offered her a left hepatectomy, harvested some lymph nodes around the area. She had a great response, and she ended up doing adjuvant chemotherapy with no evidence of disease after more than a year. She was offered chemoradiation therapy, but she had such a rough go with the chemotherapy that she thought she would decline for now and maybe do that later. So, as previously mentioned, intrahepatic cholangiocarcinoma is the only potentially curative treatment is surgical resection. The lymph nodes should be harvested, which is different from hepatocellular carcinoma because hepatocellular carcinoma doesn't generally spread to the lymph nodes, it spreads to other places via blood vessels. Now, if you can't do a surgical resection for an intrahepatic cholangiocarcinoma, you can still give systemic chemotherapy, and you can do local regional therapy, either chemoradiation, ablation, chemoembolization, or Y90 to at least control the disease and give some quality and quantity of life to these patients. Now, what about gallbladder cancer? So gallbladder cancer is similar to any of the other types of cholangiocarcinoma. Complete surgical resection with lymph node harvest is the only potentially curative treatment. A lot of gallbladder cancers in our country actually present after someone goes for gallbladder surgery for different reasons, and then they find gallbladder cancer incidentally on the specimen. Now, the biggest risk factor for gallbladder cancer, surprise, surprise, is chronic inflammation. Gallstones will cause chronic inflammation of your gallbladder. And being female is a risk factor because being female increases your risk of developing gallstones. The estrogens and progesterones that females have that men don't have as much of actually causes your bile to not move as quickly. It causes something called biliary stasis. And the bile, which is made out of cholesterol, because cholesterol helps digest fat and fats digest fat, will precipitate out into cholesterol stones. And for the same reason, obesity and diet also can be risk factors for gallbladder cancer. Gallbladder polyps, much like colon polyps, can be a precursor to cancer. And so large gallbladder polyps, we often recommend just removing the gallbladder to prevent that forming a gallbladder cancer. And also, just like for intrahepatic and hilar cholangiocarcinomas, sometimes some congenital malformations of your bile duct can cause gallbladder cancer. Some they call it anomalous pancreatico-biliary junction. What that is you normally have your bile duct going in here, your pancreatic duct going in here. They meet like a perfect V in your small intestine. The bile duct juices, the pancreatic juices mix together and help us digest everything we eat. But when they don't join like that, and they join either here or there, the pancreatic juices go up the bile duct and cause really significant inflammation, because the pancreatic juices essentially digest your bile duct, and that chronic inflammation can predispose you to both gallbladder cancer and cholangiocarcinoma in general. So complete surgical resection, like I said, is the best thing to do. This picture here is a patient that was transferred, I think, from Ottumwa for what I was told was perforated gallbladder. And it just didn't seem like a perforated gallbladder to me. She had this gallbladder mass. It seemed to be involving the liver. It seemed to be involving the colon. I checked her CA 1992 markers. They were elevated. She was older. She was female. And I just thought to myself, you know what, I'm going to treat this like a gallbladder cancer. So I offered her gallbladder cancer surgery, where basically I removed, a portion of her liver right here, her entire gallbladder, and her colon, because there was this fistula or abnormal connection between the gallbladder and colon there. And thankfully I did that, because it did turn out to be a gallbladder cancer that was invading both those organs. Now, you can see that gallbladder cancer can be pretty aggressive. You know, this was a multivisceral resection. And so for patients who have unresectable or metastatic disease, you still have chemotherapy or local regional therapy like chemoradiation therapy that you can use for these patients. Next here is a Hilar cholangiocarcinoma or a Klatskin tumor. So those are tumors that develop between the liver and the pancreas. So they're not in the liver, they're not in the pancreas, they're somewhere in between. And again, complete surgical resection is the only potential curative treatment. And this was a patient, he was actually a local mechanic. He became really itchy and went to see his primary care provider, who did a bunch of blood work, one of which were liver function tests, and he was noted to have elevated liver function tests because he was jaundiced. And bile, when you're jaundiced, that can't get secreted into your bile ducts, will cause itchiness because it irritates your skin. So I actually offered this patient a robotic extrahepatic bile duct resection, gallbladder removal, and harvesting all of his lymph nodes. So you can see here, this is his main bile duct. This is his gallbladder going into the main bile duct. And this is the collection of all the lymph nodes that I harvested with that Klatskin tumor. He had a negative resection, meaning that there was no tumors at the edges of the bile duct, but you can see the bile duct actually isn't that long. So the margins were close. So I actually referred him to Dr. Deming for chemoradiation therapy, and also an oncologist for chemotherapy to help him rid him of all the disease, because his lymph nodes were positive. So he was a stage 3, fairly advanced stage Hilar cholangiocarcinoma. And a lot of these tumors present at a stage where we can't surgically resect them, but there are other treatment options, chemotherapy, chemoradiation therapy, or potentially even liver transplant, something called the Mayo Protocol, which I was familiar with in my fellowship, where we treated these patients with upfront chemotherapy, radiation therapy, very, very hard on them. And then they got transplanted, and they often did really well in terms of how they did after the surgery, and also in terms of how they did survival-wise too. So those are Hilar cholangiocarcinomas. Extrahepatic distal cholangiocarcinoma. So remember that picture that I showed, the bile duct actually ends at the intestines and goes into the head of the pancreas to join the pancreatic duct. So you can get a bile duct tumor that doesn't actually involve the liver or the bile ducts just outside the liver. And in these circumstances, you actually need to resect or remove the head of the pancreas, the small bowel that bile duct goes into, the duodenum, the pancreatic duct, a bit of the bile duct, obviously, because it's a bile duct tumor, and the gallbladder, as well as all the associated lymph nodes. And that's something called a Whipple operation, or a pancreatoduodenectomy. And again, common theme, cholangiocarcinomas, the only potentially curable treatment is to completely resect these. And if it's not resectable, then you can offer them chemotherapy, or you can offer them chemoradiation therapy. Now that picture on the left is a Whipple specimen. And this was another local mechanic whose friends thought he looked yellow. He was jaundiced. And so he went to his doctor and got some blood work and a CT scan, and he was found to have a mass in his bile duct, and eventually underwent a Whipple operation. The nodes were positive, so he went for chemotherapy. And he unfortunately did succumb to his disease a couple years later. It was very aggressive. But he was lucky enough that we got to it to the point where we could offer him a surgical resection. And that was basically his specimen. That's what it looks like. The green is the bile duct. The blue and the red are where the veins and arteries are. And the orange is actually where the pancreas is. So we sort of mark it for the pathologist so they know what they're looking at. Now, we generally try to push the boundaries of what we can do surgically for patients. And we do that because, one, these cancers are so aggressive, and two, we know that the only way of potentially curing these cancers is to completely remove them. So this is a patient from the VA who came in with jaundice, and it was from a pancreatic tumor actually that was invading his portal vein, which is the main vein that goes to the liver from the gut. And so what we did was we did the Whipple removal, and we removed a portion of the portal vein, which is where this Q-tip is. And we have to reconstruct that portal vein. You need that portal vein to supply your liver with blood and nourishment from your gut. And so we harvested a vein from the left side of his neck, and we created a new portal vein for this patient right here. This is his head, this is his feet. And we were able to do that because we knew that if we didn't perform a margin negative resection where we completely remove the tumor, that basically this patient would have no chance of surviving, even though this is an aggressive disease. So we try to push the limits of resectability. If anyone tells you something is not resectable, we get a second opinion. You know, even if I don't think someone is resectable, I will send them out to, you know, my mentors up at Mayo Clinic in Rochester to confirm that I am not, that I'm still, that, you know, someone else agrees with me and that there isn't someone else in the world that can offer them a curative resection. We're also very aggressive for liver tumors as well. These are actually two separate patients. This is a patient with hepatocellular carcinoma, and he had underlying hepatitis C cirrhosis. And you can see here that we have a clamp across the inferior vena cava. This clamp is just underneath the right side of this patient's heart. We actually had to do this on veno-veno bypass with a cardiac anesthesiologist. And we had to do this because there was tumor inside this vein that we removed with the right side of the liver and reconstructed that vein. So we're not afraid to be aggressive because we know we have to remove these tumors to give any patient a chance of survival. This is a second patient, also with hepatocellular carcinoma. Now, he didn't actually have any chronic liver disease. He just developed hepatocellular carcinoma and was just, sometimes you're unlucky that way. And he had tumor within the right portal vein, extending into his main portal vein. So we had to remove the right side of his liver and a portion of the portal vein that we reconstructed. This here is his bile duct, and this here is his right hepatic artery. And I ink the margins so that the pathologist can look at it and confirm that I've completely removed the whole tumor. So I want to switch gears, and I only have maybe 10 or 15 more slides, but I want to talk about metastatic or secondary liver tumors. And I think this is important because a lot of people with stage 4 cancer think that they have, you know, that they're doomed, that there's no hope. And that's not true for a lot of GI cancers. So if you look at this picture, and I got this from Wikipedia, and that sounds weird, but it was actually the best picture I could find. It was even better than the textbook pictures. But you can see that all the blood supply from your gut goes to your liver, both from your colon, from your small bowel, from your pancreas, from your stomach. All of that goes through the portal vein into your liver. And the liver acts as a big washing machine. It detoxifies everything we eat and drink and everything we shouldn't eat and drink. And it cleans up all that blood and dumps it right back into the heart via the vena cava. And so tumors arising from the gut can easily spread to the liver from this portal venous system. And the most common tumors are colorectal and neuroendocrine tumors. Now, we have found that for colorectal cancers and neuroendocrine tumors of the gut that spread to the liver, we can still potentially cure these patients even though they technically have stage 4 disease. And we can cure them if we can safely remove those tumors. And there's two sort of definitions of what can be removed. There's an oncologic definition. So it really only makes sense to remove those tumors if you can remove all the tumors in the body. So if you have tumors in your lung and tumors in your liver, you got to be able to remove both of those if it's going to make sense to do it from a cancer cure perspective. You also have to be able to technically remove it, because one of the amazing things about the liver is that it can regenerate itself. If you think about all the things we shouldn't be eating and drinking on a daily basis, the liver actually gets injured all the time. And it needs to be able to regenerate itself. It's one of the very few organs in our body that can grow and regenerate itself. So you can remove up to 80% of the liver, and the 20 to 30% that you leave behind can grow back. Now, it doesn't grow back in the way that you would think it would grow back. Like, say, for instance, your liver is my 5 fingers. If I remove 3 of these fingers, the 3 fingers don't grow back. What ends up happening is the 2 fingers I leave behind actually just get bigger and take up the volume of those 3 fingers that I removed. And so you need to leave enough liver behind in order to regenerate so that you don't basically have liver failure. And for that liver to grow, it needs to have adequate blood flow to it, adequate blood flow out of it, and it needs to have preserved biliary drainage. So those are the issues that we think about as a surgeon when we say, can I cure this patient of stage 4, whatever cancer? So the most common that I'm going to talk about is colorectal liver metastasis. So about half of patients with colon cancer will develop liver metastases. And it doesn't mean that they're incurable. It means that if you can remove all their disease safely, that they can still be cured. A lot of people think 5-year survival is the benchmark for cure. And you can take a patient's 5-year survival from like 10% for stage 4 colon cancer, and you can quadruple it to up to 40% by removing those colorectal liver metastases. Now, this picture is a picture of a patient from Mason City who had bleeding per rectum and was found to have this rectal cancer, and then had staging of his rectal cancer and was found to have this liver metastasis on the right side of his liver. And when I first met him, it was a pretty small liver metastasis. And he was being treated by something called total neoadjuvant chemotherapy, where we hit this patient up front with a lot of chemotherapy to try to shrink everything down. We did chemoradiation therapy to the rectal cancer, because that's what we do for rectal cancer, to try to sterilize the margins and shrink it so that the extent of surgery is not too bad. And the problem with that is that our chemotherapy is so good, sometimes it can completely get rid of the liver tumors to the point where we can no longer see them. But we still have to remove those tumors, because when we have studied patients where we removed those tumors who had disappearing metastases, only 20% of those actually had completely dead tumors. 80% of them still had tumors in liver that supposedly didn't have any tumors that you could see with the naked eye or on a CT scan. So what I did prior to this patient starting on chemotherapies, I had the radiologist place this gold fiducial marker here, so that if he did have disappearing metastases, I could still find it and take it out. Now, he didn't end up having disappearing metastases, but as you can see that he had his tumor right here, but I was able to completely take it out. And we did this all-in-one surgery. My partner, Dr. Rahman, did his robotic rectal removal, and I did his robotic liver removal. He had one recovery. He was completely cancer-free after one operation, and he still remains cancer-free. So we can do that for these types of colon cancers. And these are what we call synchronous metastases. So these are metastases that present at the same time. Now, synchronous metastases tend to be more aggressive than metachronous metastases. So metachronous metastases is where you have colon cancer, you get it removed, and then a few years later it comes back, and that's why it's metachronous. And those are both still removable. For synchronous, you can remove them at the same time, or you can stage it. You can do, you know, either the colon cancer first, the liver cancer first, or you can do both concurrently, and that's what we try to do if it's safe and if it makes sense. And if you do them concurrently, there's really no differences in the perioperative outcomes and overall survival. So why not? But you do need to find a center that has both a liver surgeon and a colorectal surgeon in order to do those synchronously. So what about ablation? So it's a borrowed practice from what we know about hepatocellular carcinoma, and you can still ablate colorectal liver metastases. This was a patient who had a colorectal liver metastasis here, and it was so close to the inferior vena cava and so small that I actually treated it with ablation. And if it's a small enough tumor, the survival is the same, although the recurrence is slightly higher. So in order to prevent, you know, doing something crazy like where I had to remove the entire right side of the liver, reconstruct the inferior vena cava for this 1 centimeter tumor, I just went ahead and ablated, and he did really well, actually. So that's an option for colorectal liver metastases too. You can do parenchymal sparing versus anatomic resection. Basically what that means is that you remove just what's needed rather than an entire side of the liver. And a lot of these patients will have recurrence of disease, so you almost don't want to remove an entire side of the liver because you don't want to burn your bridge for doing future resections. Which brings me to my next slide. Well, what happens if you get a recurrence of your colorectal liver metastasis after your first resection? It doesn't preclude you from having a repeat resection or a repeat ablation. You know, about 40% of patients will recur, and the recurrence can be anywhere. In this case, it was at the resection margin of the previous resection, and re-resection can still improve survival. And so just because you need 2 or 3 liver resections for your colorectal liver metastasis, you know, that's still doable. Now, what if you have liver mets on the right side versus left side, and you have liver mets on both sides? Does that mean you can't be resected? Well, no, you can, as long as it's technically feasible and it makes sense. So, you know, I'm just trying to change people's attitudes in terms of liver metastases, that there's a lot we can do, even though it doesn't look good on a CT scan or MRI. Another thing that we can do, this is sort of an experimental thing, where if you have a lot of liver metastases and you don't have enough liver behind to be able to safely remove it, what you can do is you can do the stage procedure called ALPS, where you tie off the portal vein of the liver you're going to remove. You have the liver that doesn't have a tied off portal vein get bigger, and then a few days later, you remove that liver that you tied off the portal vein to, and you leave enough liver behind for the patient to not have liver failure after the surgery. Now that's still experimental, and it's not really done a lot here in North America, but it is getting a lot of traction in Europe and maybe coming to us fairly soon. Now, what if you have disease that, despite all these other things that we can do, portal vein embolization, ALPS procedure, you still can't remove the tumors? Well, you can do something called a hepatic arterial infusion pump, where you basically insert this pump directly into the blood supply to the liver, and you deliver chemotherapy to the liver with the hopes of shrinking those tumors such that they become resectable. Now, we have done that in the past here at Mercy, and I'm excited to say that we're going to start offering it again. So this is something that we can expand so that patients with colorectal liver metastases or any liver metastases, even though they're not resectable now, can potentially be resectable in the future. We talked previously about liver-directed therapies, ablation, chemoembolization, Y90. All of that is also available for colorectal liver metastases. Now, for primary liver tumors, we talked about transplant. Could you do transplant for colorectal liver metastases? Well, it isn't really done here in North America, but it is done in Netherlands, because in the Netherlands, they actually have an excess of donors to recipients, and it's because the default is to be an organ donor. You have to opt out to not be an organ donor in the Netherlands. So anytime someone dies, they're automatically considered for organ donation. And so for very select patients, and this was a very small study with only 21 patients, they did find that you could transplant patients with colorectal liver metastases, and they had a 95% one-year survival and a 60% five-year survival, which is better than the 40% five-year survival if you could resect them. And these are patients that had unresectable disease. So it's something that's in the works, just as ALPS is. More sort of traction in Europe than there is in North America now. So just stay tuned for that. Now, what about neuroendocrine or carcinoid tumors? So they're called neuroendocrine or carcinoid tumors because they're cancer-like. And just like colorectal cancers, about 50% of them will present with liver spread. And all the options I discussed for colorectal liver metastases apply. Resection, either same time as the primary or a different time. Liver-directed therapies if unresectable. Hepatic arterial infusion pumps for downstaging, and even transplant. So you guys probably remember Steve Jobs, who was the CEO of Apple. Apparently he had a pancreatic neuroendocrine tumor, and this same patient who I'm showing here also had a pancreatic neuroendocrine tumor, and it had spread to her liver. So I removed the tail and body of her pancreas laparoscopically, and then I removed her hepatic metastasis laparoscopically as well. She went home and she's doing really well. Now, Steve Jobs, his disease was a little more aggressive, and he eventually needed a transplant for it. And we do that actually here in North America, transplant for a neuroendocrine tumor. But before you even think about transplant, you can also do something called debulking, where if you can get at least 90% of the tumor, you can improve survival, you can improve symptom control, especially if your tumor is functional and is secreting hormones to make you sick, and as a result, improve your quality of life. But you do have to monitor because it's puts you at higher risk of recurrent disease. So there's a lot of options for carcinoids as well. Now, my third to last slide, what about non-neuroendocrine or non-colorectal metastases? You know, what about breast cancer or sarcoma or prostate cancer or melanoma or any of those other cancers that spread to the liver? Does that mean it's not an option? Well, not necessarily. You know, given the improvements in perioperative care and outcomes for hepatic resection and improvements in what we can offer with chemotherapy and radiation therapy, and the success of hepatic metastectomy for colorectal cancer and neuroendocrine tumors, we have expanded some of the liver resections for other types of tumors. Now, the presence of very aggressive features or large liver metastases are sort of some poor prognostic factors, but this is a patient that I offered a laparoscopic left hepatectomy for, who had squamous cell carcinoma of the rectum that had spread to the liver, and that was her only site of disease. And you know, she had probably 1 or 2 years of being completely cancer-free before it came back, and that was better than being on chemotherapy that entire time. So we can consider it for sort of more, sort of less traditional indications. So just to summarize, the only potential curable options for primary liver cancer is HCC or cholangiocarcinoma is complete surgical resection. And I just sort of have a little schematic of the different types of surgical resections we can do. Secondary liver metastases from either colorectal or neuroendocrine tumors can also be cured, even if it's stage 4 disease, by surgical resection. And there may be evolving indications for other types of tumors for doing a liver resection as well. So I want to conclude by thanking Dr. Deming and the Mercy Cancer Center for this opportunity. I'm happy to take any questions. My phone number and email are up there for you at any time. This is kind of an old photo, but it's the best one I have right now. And I want to acknowledge my senior partner, Dr. Jan Franco, who is actually the division head of surgical oncology, and also Dr. Brombaugh, who's my friend and colleague who trained with me at Mayo Clinic, but has left now, so that's why it's an old picture. But we have recruited another surgical oncologist, so it's still going to be 3 of us here to serve anyone that needs our help. Thank you.
Great, thank you, May. That was awesome. What a great talk. I just marveled not only at your expertise, but at your how articulate you are and what a wonderful presentation. While we're waiting for other questions, I'm going to get a little personal here. So how do you learn to do these very, very complex surgeries? So obviously you don't get to, as a medical student and a surgical resident, get to do the very first Whipple you see. So do you have surgical educational sessions with animals during your residency and fellowship, like with pigs or dogs or other animals? And then tell us a little bit about what it takes in training to actually get the expertise to be able to do these highly complex surgeries.
That's a great question, Dick. So your first question, do we learn on animal models? The answer is yes. When I was training in Vancouver, we did have pig labs to do basic surgeries as a way to train. We actually also had human cadavers, and they were often donated altruistically for that purpose, where we could do dissections and really understand the surgical anatomy. In terms of training, so I graduated high school in 2000, the year 2000, and I got my first real job in 2018, which was here. So you can imagine how much training I did. You know, I was fortunate to be in a very high volume surgical residency where we did a lot of transplant, a lot of liver, pancreas surgery. And so by the time I went to Mayo Clinic, I had enough exposure to hit the ground running, and you know, we operated a ton there. I think I did 400 or 500 cases in my two years there, and then I had also supplemented that training with a little bit of transplant training as well, just to really be able to get the technical skills, especially with all the vascular work and being able to expand what I could say was technically resectable for patients.
And also, can you comment a little bit more about the multidisciplinary nature of cancer treatment? So you did talk about bringing in radiation therapy, medical oncology, the interventional radiologist, and maybe for the audience that consists of cancer survivors and their families, how does this multidisciplinary approach work? Who's the captain of the team? How do you figure out what to do? What if there's different options? How do we as physicians and patients come together to figure out what's the best option for an individual patient?
That's a great question, Dick, and I should have emphasized it more during my presentation, but you know, being able to deliver this high level of cancer care really relies on a team of experts such as yourself and oncologists and interventional radiologists. These are very highly aggressive tumors, and often one treatment alone is not going to be enough. And ultimately, every patient is different. And, one of the things that I think works really well at Mercy is that we all sort of interconnect well, and we have the patient's best interests at heart. And really, it's the patient that's the captain of their care, in terms of, we offer them the different options, and they, we give them all the tools to make an informed decision for what works for them. But yeah, we can't do this without our multidisciplinary cancer conference that you chair on a weekly basis. I learn every time I go to those cancer conferences, and we also can't do what we do and offer these patients this kind of complex cancer care without all the nurses and allied health involved as well. Everyone from our dietitians to our nurse navigators to our OR nurses, who often stay overtime for these cases because they take often 10 to 12 hours to do.
Yeah, thank you. Yes, it's definitely a team. And as Dr. T pointed out, we have multidisciplinary cancer conference. We actually have 12 of them a month that radiation oncologists, medical oncologists, surgeons, pathologists, diagnostic radiologists, interventional radiologists, genetics counselors, dietitians, palliative care specialists, our research team all attend, and the cases are presented, and we look at national guidelines, we look at the options. And as Dr. T also pointed out, really the patients, their performance status, which means how healthy are they, how fit are they, is it a 95-year-old patient with 5 heart attacks and 2 strokes, not likely to be able to undergo a great big 8-hour surgery, or are they a 50-year-old marathon runner that doesn't have any underlying heart and lung disease? That factors in. Also, the patient's own desire, like if you're going to offer someone a liver transplant for a cancer, that's a huge commitment, not only on the part of the surgeons and the donor, which is usually someone who's lost their life, but also a huge commitment on the patient and the family to undergo something like that. So we believe in what we call informed decision making, where patients and the physicians discuss the risks and benefits of the various options. Chris, do we have any questions through the chat box?
No, none that I see. It was just fascinating, though. My goodness. Wow.
Yeah. So May, this talk is just a beautiful talk, and I think, and not only was it great for cancer survivors, but it will be hosted on our YouTube, and we'll get you the address for that, because I think this would be wonderful for medical students and certainly surgical residents and others, individuals in cancer care, to be able to go to as a reference. Very thorough. Thank you. Really appreciate it.
Thank you for the opportunity. Thank you, guys.
Thanks, Dr. T.
Have a good evening. Thanks, everybody.
Thank you.